All right.
Hello, hello, hello,
Hi.
everybody. So I'm so excited tonight. I have one of my esteemed colleagues, Dr. Greeter, here with us. She is an amazing psychiatrist that's here local in the area with me. And tonight we want to have a conversation, and that's exactly what it is, a conversation about PMDD, neurodivergence, medication, and really all things related to that. So why don't you introduce yourself, Dr. Greeter?
Hi. Thanks, Dr. Sarah. So, I am a child, adolescent, and adult psychiatrist. I have a practice in Sarasota, Florida. I also treat patients throughout Florida, Washington State, and Colorado. And I am autistic and ADHD myself with a lot of complex chronic health issues. So I'm particularly passionate about advocating for the neurodivergent population.
Yay. And you all already know me and my mission and passion for the neurodivergent population as well. I also have
Yeah.
ADHD. So that's what brings us here together. And we were just talking before this about
hmm
that women, I think the last time I looked at the statistic, it was 8% of women have PMDD, and then 40% of those have neurodivergence, I think is the statistic that I looked at last.
Okay.
There's something to that matter.
Yes, and then there are some studies. Now these are smaller studies, and we definitely need a lot more studies because it varies a lot from study to study. But there are studies where they take populations of women who are autistic and not autistic, and you know, it was something like in women who are ADHD and not ADHD, it was something like 45 to 46% of women with ADHD reported PMDD compared to like 3 to 8% in the general population. And then in a smaller study of autistic women, it was like even higher, like we're talking in the like 80 something percent compared to non autistic. So there is definitely some evidence to indicate that neurodivergent brains are more sensitive to hormonal fluctuations.
And do you see that like live every day in your practice from treating all these women?
Yes, yes, yes,
And
yes.
I see that very much too. And this is why the conversation is important on so many levels. But from a hormone replacement perspective, not even looking at just at PMDD, but looking at, let's just say perimenopausal
hmm
women that are neurodivergent, a lot of them will try or attempt hormone replacement therapy and then they will fail, right? Or they don't fail. The person giving them the medication fails because they don't understand the sensitivities. So these women in my practice, I mean, sometimes I have women on a quarter dose, right, of estrogen until we can get
Yeah.
that system to be built where it needs to be. And that's where I see the same that the way that they process or we process because I am one of them, the way that we process medications, especially from a hormonal perspective, is just different.
I think medications across the board, especially in psychiatry, I'll say, it's not that there are special psychiatric medications for autism, so much as I think autistic people are more likely to have idiosyncratic, unique responses and sensitivities than other non-autistic people. And then I would say for our ADHDers, I do see that. I do see that they may need to have more medication trials before finding the right fit too.
Yeah. Yeah, and it makes sense to me from a brain standpoint, like understanding what's happening, in the brain in their
hmm
processes. But I guess let's talk about PMDD for a second, and
Okay.
because I also think that it's great when they find you or I, but so many of them don't ever find you or I, or not until they're, really late, or after a lot of struggle, a lot of medical trauma, right? Before a lot of gaslighting
Yeah.
dismissed, unfortunately. So if we could get our eyes on every person that had PMDD before anybody else, like what would your, biggest like advice be?
I mean, I think you speak to invalidation, so that that this is really real and true, and a huge PMDD has a huge impact on quality of life and the health of their other relationships too. So I see not just it be a struggle for the individual woman or assigned female at birth individual, but also their whole family in terms of how they relate to their family and a lot of relationship conflict if PMDD is left unrecognized and untreated. So, unfortunately, I think I think it would be nice if there was more screening for women and those raised female at birth for fluctuations and mood symptoms that change with their menstrual cycle.
Yeah, and that's just not saying like this is normal, right? Like, oh,
Mhm.
it's normal for your period, this is normal. It's actually not, right? PMDD symptoms, if your period is incapacitating you, if the week before your period you can't get out of bed, you're, if for a teenager perspective, you can't go to school. If you're a woman, these are girls I see, right? They can't function at all. That isn't normal, right? That shouldn't be happening. And we need to do a bigger, deeper dive and look at that. I want to say one thing that
Mhm.
I see. I don't want to use the word commonly because I haven't treated thousands of PMDD patients, but treating hundreds. I can say that there's a couple of things that I would say if like you have these PMDD symptoms that you should definitely have looked at from a whole perspective. Is really a complete amount of blood work, right? So not just a CBC and a chemistry, but really looking at the thyroid completely, right? Not just a TSH, right? Looking at a T4, a T3, looking at thyroid peroxidase antibodies, right? I would also say something.
Also, iron studies I think are really important. I see a lot of these
Ooh.
women complaining of fatigue and depression, and nobody ever checked a ferritin on them. And then an, I think like one of my pet peeves too is treating people based on some kind of random reference range in blood work as opposed to treating people for optimal health. What are the levels that we would see for you to be healthy, not just, you know, keeping you out of disease, but actually optimizing health.
And that's huge. And ferritin is a really good one because actually ferritin plays into the way ferritin is processed in the body. It plays right directly into dopamine, right? And so
And it impacts ADHD symptoms
yeah.
100%.
But what people don't know is the optimal level, right? What's green in between the green?
Yes.
15 is green. The optimal level of ferritin in a woman should be 70 to 100. That is a vast difference,
Yeah.
right?
This happened to me actually recently personally. So I was sitting in there, I was sitting at the hematologist office like 4 weeks ago, and I'm sitting there with the ferritin of 22, and I'm like, please, I think I need another iron infusion because I have celiac, so I also don't absorb my iron very well. And they were like, no, this ferritin is fine. This has nothing to do with your fatigue. Doobie doo, right? So, I mean, um, it it's really frustrating. I don't think that there's enough um, education about what is optimal for health. There's simply a lot of training about like treating a disease state when it's diseased. Does that make sense? Am I making sense? Yeah.
Well, that's that's what medicine is currently, right? It's very much, I learned this in med school, as I'm sure you did. Oh, this person has this disease, this is what we give them. This is what we do.
Right.
It's not, oh, hey, and also I wasn't really trained before I did integrative medicine. I wasn't really
Yeah.
trained what optimal labs are.
True. Me neither.
Oh, oh, it's green, like that must be normal. And by the
Yeah.
way, you know how they get that, right? It's like but they take 100 people between 3 and 93, and that's how they get a range. It's like
Yes.
that's clearly not optimal for anyone. And also, I would say to you, like the person listening to this, and to us as providers and physicians, also treating patients, that if patients' labs, look normal and they still have symptoms, something is going on.
Yeah, treat the patient, not the lab value.
And we see this a lot with subclinical hypothyroid, right? Patients
Mhm.
will, their TSH will be maybe just a tiny bit. Okay,
Right.
let's
It's
watch.
like 3.5, and they're like, that's fine,
It's
right?
like,
But no, a healthy TSH is like ideally around one. So,
exactly.
so really thinking that through. And then, you don't want to continuously throw antidepressants at subclinical hypothyroidism. And you also don't want to overtreat people, right? And give them tachycardia, et cetera. So
Yeah.
that's another frustrating piece of this is on the other end is like some people are, I think, overtreating, and many other people are undertreating.
Yeah,
So both
no,
sides.
there is two sides of the spectrum. That's actually
Yeah,
why I really like integrative medicine for what my
right.
term of that means, because we're taking both of the sides
Mhm.
and kind of meeting that in the middle. And are more medicine heavy than others. It depends on the person. Really, this should be physician guided precision medicine. That means what we treat you with isn't going to be the same thing we treat myself with. It's not going to work the same
Right.
on both of us. And it's kind of, silly thinking that that would, right? Like, oh, here's this dose of SSRI. That's going to work on the same on you as it is on me. And my vitamin D is 33 and yours is 33. And if we take the same dose, that's going to actually work for both of us also. Right? No, it doesn't work. Either
Yeah.
one of those things don't work. It's definitely got to be for like who we are and the person and patient that you're seeing in front of you and a lot of the other factors that they have on, going on in their
Hmm.
life. But definitely, we have got to look a little bit deeper and understand labs a little bit, does that mean that I also want to say, like, does that mean that if your ferritin is 33 and we get it to 70, that all your symptoms poof go away and all is right in the world?
Right. And then there's some data that if you have a chronic inflammatory process like Crohn's disease, celiac, etc., you maybe want a ferritin around 100 is more ideal because that chronic inflammation artificially elevates your ferritin. So, so many things to consider.
Yeah. But the moral of it, I think, is that it's not as simple as we need to be definitely looking like a little bit deeper.
Yes. So let's go deeper.
Okay.
ADHD and the you said that. You said
I
it. You,
know.
you set it up. You set
I
it up.
did.
Yeah, I mean, so ADHD and the menstrual cycle, there's data that around the time of ovulation, the bump up in hormones can enhance the hyperactivity and impulsivity symptoms of ADHD. There can be some increased risk-taking behaviors around the time of ovulation. Isn't that great, right?
Yeah.
Um, then there's the dip in estrogen and the drop in estrogen during that luteal phase can decrease your dopaminergic tone so that you're less responsive to your stimulant medication. You may have to increase the dose of the stimulant during the luteal phase, and then women can be more responsive to their stimulant during the follicular phase of the menstrual cycle. So, and yet I don't see many clinicians doing like fine tuning or letting people have changes in their dosages throughout their menstrual cycle. Um, Sometimes, my patients will need a higher dose of their SSRI during their luteal phase as well. Um, so I think being mindful of that, that doesn't happen and again, this isn't one size fits all. Some women don't notice any difference
Yeah.
throughout their menstrual cycle. And it doesn't mean having, let's say having going back to PMDD, I try to emphasize PMDD doesn't mean that your levels of hormones are abnormal because it's like a natural part of your cycle to have this fluctuation. It means that your brain is more sensitive and your emotional state is more sensitive to normal fluctuations that we all have.
Yes, absolutely. And that's why people will say, and there's that common theme where like your
Yeah.
labs are normal. And outside of the
Right.
things we talked about, like thyroid and ferritin, well, it is, I mean, checking an estradiol is irrelevant in most cases, right?
Yeah.
It's a one matter in time. The other thing to think about, especially from a PMDD and in luteal phase, is that is when estrogen is at its lowest, right? We know that estrogen receptors work on the prefrontal cortex. Estrogen directly relates to dopamine with so many
Right.
things.
So drop in estrogen can cause a lot of difficulties with executive functioning.
Right. And so that, and also as they process their medications, right, then as that goes down and lowers, then of course the stimulant medication that was working well in follicular phase when estrogen was here, now estrogen's here, right? And now also we're having a harder time activating dopamine, that's on a low level. And now, so now, of course, their medication feels differently, that it's not working as well or whatever the case. And interesting enough, I actually see in clinical practice a lot of neurodivergent women that will have trouble right after ovulation. So ovulation is fine. And this is when a lot of them will get diagnosed with POTS. They'll start having all of these symptoms. And actually, I think it goes back again to the fact that there's no vast change in hormones right at that time, right? Ovulation is the peak, and there's no horrible, but there is a slope of estrogen at that point that starts to decline into luteal.
Mhm.
It's not like crazy, right? It's just like this. And some of those women are very, very, very sensitive to that.
There's a huge amount of POTS. There's a huge overlap between POTS and neurodivergence as well. I think another thing to think about too is autism and ADHD. It doesn't just, you don't just have a different brain, you have an entirely different whole body.
Yes.
So there's a lot of overlap between autoimmune disorders and neurodivergence between um, like you mentioned, because you're mentioning thyroid stuff. Um, and there's a lot of data that there's different an overlap between connective tissue disorders, hypermobility, and neurodivergence. The list really goes on and on. A lot of endometriosis,
Yeah.
a lot of PCOS
Yeah. And
in the
then you add
neurodivergent population.
and when you add in PCOS, and then this also plays into
Mhm.
perimenopause too. Remember, because there is a school of thought, and a lot of women or girls that are diagnosed with PMDD, a lot of them will trial actually on progesterone in the second half of the cycle. And a lot of them do really well with that. But why? Because if you have endometriosis or especially PCOS, if you do not ovulate, you do not make progesterone, right? What makes progesterone is the corpus luteum. You have to ovulate to make progesterone. And we see that also in perimenopause when they're having anovulatory cycles, and we're not tracking them, right? This isn't fertility. So they're not, peeing on the sick looking for their LH surgeon if they're ovulating. But if you don't ovulate, now that whole second half of that cycle, you have no progesterone. Right. And as we know, progesterone breaks down to alpregninolone, which is a GABA, works on GABA. So now we bring in a whole other, potential issue in that state. And you said it right, like vascularity is an issue, POTS, all of these types of things. We see that, women are I'm telling you, and I need to look more at the studies, or we need to do a lot more studies, as you said earlier. But there's something to this. There's a certain subset that have this. Some of them have POTS diagnosis, some aren't diagnosed, but it's right after ovulation that almost
Okay.
all the time that those symptoms are, and they're mostly never throughout the rest of the cycle
It's
associated with.
interesting. I have a lot of POTS patients. I'm POTS myself, actually. But I didn't know that I have not, I can ask about it, but I haven't yet experienced people who have it just around ovulation yet. It
Interesting.
would be nice to only have my POTS around
Yeah,
ovulation. And then when I don't
yeah.
ovulate, never
And
have
you're like,
POTS again.
okay,
That would be nice.
like I'm fine. Just count me out for these couple of days, and then I'm okay with that. So I guess from an ADHD perspective,
Mhm.
if that someone is noticing that they're having these changes, cyclically, from a psychiatric like medication perspective, is it okay to be dose adjusting, for different times of the menstrual cycle?
It is. I think it's a lot easier with stimulant medication because they're so rapid. And there's a lot more, I think there's a lot more data to support the adjustments of stimulants versus the adjustment of SSRIs and SNRIs. But some there are the thing is that patients rarely just have PMDD, and that is their only psychiatric diagnosis. So while it is theoretically possible that someone with PMDD could only take an SSRI for 14 days just during their luteal phase and be okay, I think in clinical practice, my patients do better taking the SSRI every day and
Yeah.
having a stable dose because it can be confusing for them. So I do find it more effective to be adjusting the ADHD med based on the cycle. And like for my PMDD patients, a lot of times I'm like, why don't you just stay on the dose of SSRI that makes you feel good throughout the month?
Yeah, yeah. And I would say too that this word, I feel like it's the word of 2026, which is mitochondria. I feel like
Yeah,
mitochondrial health is so important.
it
Number one,
is.
well, number one, we're the most mitochondrial diverse and where dense, I mean, in our ovary and our brain, right? Like those are the two, and then it's our heart and our thyroid come after that. But mitochondria are so important, even and we don't realize how much mitochondrial trauma, I guess, we get just from living everyday life, right? We kind of live this fake
Well,
life.
I mean, there's a lot of, especially with in the long COVID era, we are beginning to really understand how viruses impact mitochondrial function, in the long term.
Yeah. And mo like the last statistic I looked at, I just came back from a longevity conference not that long ago. 96% of Americans have some sort of mitochondrial dysfunction. Now, that's not mitochondrial disease that we're talking about, but
Yeah,
some sort of complex one, three dysfunction based on either medications they're on, processed foods they're eating, some sort of this, this or that. There's some degree of, right, mitochondrial dysfunction. And I think that
but
plays
what
a
do you think is
role
the most common cause of mitochondrial dysfunction?
in Americans.
Yeah.
I think two
Should
things.
I guess? Should I
Yeah.
guess? Or do you want to tell me you want me to guess?
No, I want you to guess. Yeah.
Oh, God. I mean, alcohol?
Okay, that's up
No,
there. It's not
it's
number
up there.
one.
It's not the number one though. Metabolic, is it like metabolic syndromes?
Well,
Okay,
metabolic
all right, I
syndrome
give up.
play
Tell me
in.
the answer.
Um, so it's actually processed food
Processed food.
because most
So
of
having an inflammatory diet.
Oh yeah, inflammatory and, full of toxins and chemicals, right? And so and that a lot of time we can't help that, right? Actually, until I really started educating myself on what that meant, I had no idea. I did an experiment where I took the Yuka app, I'm sure you're familiar with it, and I went into the grocery store and I found every single thing that I thought as a physician looked
Yeah,
healthy, right? Like, okay, this is, Kit Kats aren't healthy, right? There's certain things, but it was like, this looks like it would be pretty good. And I scanned it and I tell you, I almost had a mental breakdown, literally, in that store. I was like,
okay.
let me tell you, do you know that goldfish that we feed our children, that we're
Yeah,
feeding toddlers on a daily basis, has 18 artificial additives, four of which are high risk?
yeah,
Gold.
I can believe that. It's a good thing I don't eat goldfish. I have
I
celiac though,
know.
so I can't
I
eat goldfish. So they have wheat and gluten, so.
Yeah. So maybe you're lucky in a certain way for your celiac. There's some parts of that that may be lucky. But actually, that brings up another point. You
Yeah,
say, gluten. A lot of people we find, right, have gluten, not just gluten allergy, but maybe a little bit of intolerance. But interestingly enough, they go to Italy and they go and eat all this pasta and they're fine. So is it the gluten or is it what we do to it here in America, right, to
yeah.
process? That's really the
I
problem.
do think there's something to be said for that. Yes.
It's been interesting. Like I've had some patients who've done that, right? They're like, I just ate all the pasta in the whole world when I was in Italy, and it's like, okay, that's an interesting perspective. But that has a lot to do with it. The other thing is artificial light. So we sit under artificial light all day long, right? We are a society that doesn't, we're not back in the day where you're hunting and gathering and you're
Right.
working outside. We are under artificial light, which has a huge impact on mitochondrial function.
Yeah. Interesting. I didn't know that.
And then also too, like some things, we're in different medications and stuff, right? We know that they impair mitochondria, right? So for example, metformin, impairs complex one of mitochondria, right? So we know that lots of different medications can impact mitochondria. So does that mean that we shouldn't be on the medication or that we don't need it? No. But what it does mean is that if you are someone prescribing these medications, you have to have an awareness of what the downward effects are, right? Do you know how many patients, and I'll use statins because they have the bad rap anyway.
Yeah.
So, but do you know how many patients are on statins and don't take CoQ10? When it's documented for
Yeah.
decades in the cardiovascular literature that statins deplete CoQ10, where is CoQ10? I'm just going to show you because I'm such a nerd. Here's the mitochondria. Here's CoQ10, folks, right
Yeah.
here,
What do
right?
people do if they need to take metformin too?
So, well, you can use other medications, or if metformin is the thing that works for your insulin
Yeah.
resistance, then you just replete with CoQ10, right? It's a partial inhibition of complex one, so it doesn't fully
Yeah.
inhibit complex one. But the point is, we have to be on certain medications, right, that have these downward effects. What I
I
would
do
say
love my
is,
CoQ10.
I know, I love it too. Victorol is amazing. But the thought is like we were talking about earlier, like, okay, we were taught the normals, right? Or what this normal is. This is where the thought has to come in. If you are a physician that is prescribing medications to patients, you should have an idea of the downward effects of these. And so they can be on them. Like, why do we have all these cardiac patients on all these meds and no one's taking magnesium? Right? Magnesium is responsible for 300 enzymatic reactions in the body, right? It's responsible for neurotransmitters. It's part of all of these sequences
Yeah.
of events that happen. And it's super easy and it's cheap, right? But we're so much taught like, okay, this medicine, this medicine, that we're not looking at the overall person. And this happens a lot to everyone. It happens a lot to women. And I think it plays a role in neurodivergence, whether we're talking PMDD, perimenopause neurodivergence with no other issue but neurodivergence, is that they sometimes this is what's happening, right? Is we're not looking at the entire person. And so again, if we're pulling these tiny little levers, which is really what
Mhm.
health optimization is, right? Again, it's not you fix that ferritin, that doesn't mean that poof, everything is good. You optimize
Right.
the vitamin D, that doesn't mean poof, everything is good. But if you fix the ferritin, if you optimize the vitamin D, if you improve their mitochondrial health by 10 to 15%, if you get them on the right dose of stimulant, if you optimize their hormones, if that's what needs to be done, well, that's when everything comes together, right? It's not one thing isn't the boom, wham bam, now your life is better. Not to mention, then we have to get them moving and exercising and getting some
Yeah.
sun things, right? But guess what? They can't do any of that if they don't have cellular capacity, right? If
True.
you are like,
You
I
can't
can't,
take someone who's depleted and be like, well, you should just exercise more,
right?
right? When you're already incredibly depleted.
Yeah, that's like literally the definition of insanity. Like, that doesn't make any sense. They have zero cellular capacity. And I see that a lot in the PMDD girls that end up in my office where it's like, I was told, I went on a birth control, I went on an SSRI, that didn't work. They told me like walk more and like, exercise. It's like, they can't even get out of bed for 7 days. Like, how do you expect them
Yeah.
to walk more and exercise? Yes, that needs to be done, but we have to do something first. We have to pull some levers, right? And these are these are very complex patients to manage. I don't by any means want to pretend that this is an easy thing again and say, like, oh, take your vitamin D and life changes. No, they're very complex, but it also deserves a complex conversation.
Indeed.
Yeah. Okay, tell me what you want to talk about now.
What do I want to talk about now? Well, I think it's interesting. I think that there's a lot of data that women and those raised female um, who have PMDD are also more at risk for postpartum depression and are also more at risk for a lot of mood dysregulation during perimenopause. So it does seem to track that brain sensitivity to hormonal fluctuations will happen at all those different lynch points where there's huge hormonal fluctuations
Yeah.
with the menstrual cycle, in the postpartum period and then in the perimenopause period.
And we talked about something that we touched on it a tad bit. You said when I asked you, like, in an ideal world, you said about screening. And I think that's
Yes.
exactly where this has to go, right? Because if someone has PMDD, are we talking to them? Are we educating them about, hey, when you do or if you do get pregnant, this is what this could look like. This is what you're at risk for. This is how
Yeah.
we're going to monitor you, right? When
Right.
after and postpartum. And I just did a YouTube about postpartum is so much more than, your 6 week checkup. And it was about
Yeah.
women understanding, like, not even neurodivergence, just understanding what your body and your brain and everything goes through. But, like, why aren't we having these types of checkups? If you already have PMDD and you're at risk, why aren't we having postpartum checkups that are including all of this stuff? A lot of the women that come to me that have had postpartum depression or some
Yeah.
postpartum psychosis tell me that all that they were being asked was like, or they said, I feel down. And they're like, well, that's normal. No, it's
Yeah.
it
I
really,
think I also think a whole nother episode could be on reproductive psychiatry because I feel like there are few more stigmatizing and harmful myths than the myths that people have about psychiatric medications during pregnancy and
yeah.
postpartum. Um, the data vastly shows that it's healthiest for a baby, for a mom to be psychologically healthy during that time and for her to be able to attach in a healthy way to her baby and be supported by her family. So um, there's a huge amount of fear, and not just in patients, but also, Sarah, in the medical community. Like so many of my patients will go in to their visit, and it won't even some random nurse at the OB office is like, oh, you can't take these meds while pregnant, by the way. And they don't have any background
Right.
knowledge about the risks and benefits. There isn't much discussion at all about the risks that people take for themselves and their baby when they discontinue these medications. So it's really important. Don't make the assumption that zero medication is the least harmful choice,
Oh, yeah.
because we are comparing the risk of medication to the risk of untreated psychiatric illness that does have a big impact. And yet there's a lot of, I think, unnecessary guilt that these women are subject to by the medical professionals.
Yeah, and you brought this up again, and it's about why the conversations that we should be having versus the ones that we are. And those are complex conversations, right? Those are conversations we're not educating our patients well enough. And I don't mean you and I mean the world in general, right? When if a woman stops taking these medications, nobody has talked to her and given her the right information. These are risk benefit questions, ratios. This is shared decision making. These are,
Mm-hmm.
I always tell everyone, I don't care if you take hormones. I don't care if you don't. I don't care if you take a stimulant. I don't care if you don't. What I care about is that you understand the risks, you understand the benefits, and you make a decision for yourself. And that's the conversation that's not being had, right? It's like, hey, you're on this medication. Here's another part of it. These are all of the things that we're going to do to optimize you on this medication while you're pregnant, right? To make sure that your baby stays safe, that you stay safe, your brain stays safe. We're going to monitor this and we're going to monitor, I mean, simple stuff, right?
Yeah.
We're going to make sure your mitochondria up. We're going to make sure you have adequate CoQ10. So, and talking in that level and them experiencing whole health, which is what they're missing, right? It's again,
Mm-hmm.
this fragmented stuff. Like you go into the OB and some nurse that has no business, and I love nurses, my
Right.
husband's one, but has no business telling a woman anything about that
Right.
is saying this. And then guess what we do? We internalize that and we're like, oh my God. And because no one wants to harm their baby, right? Nobody wants to do that.
Right.
Right. So then we do take on that guilt, but you're 100% correct. A mom that untreated psychiatric illness is the worst case scenario for a mom and for a baby, right? And then when mom goes into postpartum depression or psychosis or whatever after that,
Yeah.
that could have been maybe prevented or at least lessened if we were having those conversations. We're really doing them a disservice, honestly.
Yeah. Most commonly, postpartum psychosis is related to untreated bipolar disorder. And a lot of um, women and those raised female at birth with bipolar disorder are also have PMDD. So there is a huge overlap there too.
Yeah. Yeah. And then do you see that connection to autism at all?
Be- Between autism and PMDD or autism and
Bipolar.
bipolar? Oh, I don't know about autism and bipolar. I think it's tricky. I honestly think, Sarah, that there's a lot of women who are dysregulated and have meltdowns and do impulsive stuff because they're ADHD, and the label of bipolar gets put on them when really autism and ADHD are more accurate description of what's happening to them. But there can certainly be overlap, or the other label that could be put on them is borderline personality disorder. Now you can have borderline personality disorder and autism and ADHD, all of the above, because, not having undiagnosed autism and ADHD and lack of support is increases your trauma risk and risk for personality disorder. So, but I think that we have a huge population of kind of missed, they call them the missed girl, the lost girls, who their diagnosis of autism and ADHD was missed in their childhood, and they've gotten so many different diagnoses under the sun, before finally, often it's because their kid just got diagnosed as
Yeah.
autistic and ADHD, and they're like, but I have all had the same stuff.
Yeah, but that's me 15 years ago. Yeah, and
Yeah,
you hit that on. There is and you know what? The other thing is there's a cost to that, right? And not only
yeah,
is it the cost, the years of misdiagnosis and maltreatment, really
yeah,
mistreatment, not getting the correct treatment. But then when you do get them the correct treatment, there's a huge piece of grief. There's anger. There's all
mhm,
these things that they have to go through, right? And it's almost like I say, like when a kid who's adopted that never knew it at 20 finds out that they are, and then they're like, oh my gosh, my whole life was a lie. And that's actually, I see that in my practice a lot, where they finally get it. And you would think like, okay, now you got the right diagnosis, we can get on the right path. And that's not it, right? There's so much more, because now they're like, why did you miss it? Why did you miss it? Why didn't I do this? Why, there's like a whole process that comes after they finally like get
yeah.
that right.
I mean, that's so individual specific. I think I can speak to my own experience, and I walk this path with a lot of people. I think it can be incredibly validating where, and you can shift the narrative from I'm so weird and all this idiosyncratic stuff that doesn't make sense to, oh, I am autistic. That is what is going on. My brain is literally different. And there's other people like me who are also autistic, and I can, people who mirror my experience of the world. I think that there's could be some relief um, in changing the narrative of ADHD from, oh, I'm lazy, selfish, etc., to, you know, you're not weak. I say you're carrying heavier weights around than other people are. Kind of like, think about going to the gym and all these years, you think that you're lifting the same weight as everyone else because they look exactly the same, but for you, it's actually heavier. You had no idea.
Yeah.
Some people talk about it like playing life on hard mode, like a video game. I think it's really important in someone's process that the diagnosis is only the beginning.
Yeah.
And so I have a list. I have a list of post-diagnosis self-reflection questions. I can send that to you, of
Yeah.
course, Sarah. Where it's like, I used to believe blank about myself. Now that I know I'm autistic, ADHD, dyslexic, etc., um, what I know that actually blank is true about myself. The things that I most value about my brain, the things that are hardest for me about my brain. When other people labeled me dot, 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 now I know what was actually going on was dot, dot, dot. And like going through that process of shifting the narrative and then connecting people to a neurodivergent community, so they can find their, I call them neurokin,
I love that word. That's great.
right? To really, you know, have to feel really seen and understood. Um, so the diagnosis is really just the beginning of a process. And I don't know, like I imagine you wonder, what if your ADHD was diagnosed earlier in life? What if my autism was diagnosed earlier in life? I mean, it would have been nice to have this self-knowledge and self-understanding earlier. Um, but um, you know, maybe I would have been like thrown in special ed and gotten ABA
Right.
out the wazoo, and you just really don't know.
Well, and we don't want to spend a lot of time there, right? Like they're
Right.
gonna, if they're having these and going through that, that's okay. That's completely great. But I also think you're right. The faster we get them to their neurokin, the better.
Yeah.
I actually have a Substack. It's only written for neurodivergent women in midlife. And what the things that I see, hear, and read and feel, it's like it has been the most rewarding thing that I've ever done, to be honest with
Yeah.
you. Because these to see these women and their expression and them come out and say, "Oh my gosh, me too," or like, "Holy cow, like this is me."
It's
And
like the idea is you are not alone, and
yeah.
there's a group of people with whom you belong.
Yeah. Yeah. And then, hey, let's talk about like who we are, what we can do, how, and there's all
Yeah.
this specific subset, they're always looking for, okay, now this is it. So now what? How do I optimize? What is this? Or the question like, hey, does your, ADHD medicine feel different to you? Right.
Right.
And for people like you and and I always say this, like, I feel like everyone in the world knows all the things that I know about neurodivergence and just about, integrative medicine and how things should be. And we mentioned labs and how what optimal labs actually are. Like because it's so much of my world, I feel
Right.
like everyone else should knows all of that, but they don't. And so I think it's just important for us and
Yeah.
important for other providers, right? To also understand that I don't expect, and I'm not an expert, right, in neurodivergence. I leave that piece up to you. But if we have these communities, like physicians need communities too. And
Yeah.
we're kind of think about it like a lot of times where you train and you're just in your zeitgeist, you're in your zone, right? And you're surrounded with whoever you are. And if they're seeing 40 or 50 patients a day, they're not reading journals,
It's going to
right? They
be
don't
hard.
have time for that.
I think I have a lot to say on the topic. I think it's so key to remain humble and curious, okay? That the ability to accept when you're wrong and then pivot and change
Yeah.
your treatment philosophy, your clinical approach, your diagnosis, so important. I have a theory too that I think during medical training, it isn't safe to be wrong. It's like you have to prove that you know enough to deserve to not be outed from the tribe of medicine, or else just you're out of here, right? Like
Yeah.
public shaming while being pimped on rounds.
Yeah.
And I think that sets physicians up to be defensive when presented with information that might indicate that they were wrong about something, as opposed to embracing being wrong is a healthy part of the learning and growth process, because medicine changes constantly. So what we thought 10 years ago, 5 years ago, 5 years in the future, like what am I going to know about neurodivergence 5 years in the future, where I look back on myself today and was like, oh my God, that's so embarrassing. Why did I think that? Well,
because we thought
right?
that with the best information that we had to
Right.
get.
But it's changing. It's
Yeah.
changing. So I really like I tell my residents all the time, I'm like, cultivate your curiosity and your tolerance of being incorrect,
Yeah, and saying that.
non-defensiveness.
Yeah, I always tell patients, I'm like, listen, I'll be the first one to tell you what we know, what the studies show, and what we don't know, and what we may never know. And something that I might have thought was right a year ago, I may not think is right today, and I'll be able to tell you that, right? And I'm going to explain that to you, and we can talk about that. But you bring up that great point. Another thing about residents is I'm the simulation director for residents, and that is cultivating a safe space, right? That's like one of my
Mhm.
main jobs is to cultivate a safe space for them to make the mistakes, for them to do these things.
Yes.
When I first just took over, which was very recently, the senior residents were actually not showing up to sim. They were checking, they were scanning a QR code and leaving. And I
Hmm.
said to the sim director, why are they doing that? And she's like, they're embarrassed of some of the things they don't know, or they feel like they should. So, I did a sim just for the senior residents, and we did an ultrasound lab, and I was teaching them stuff, and I used that time to work with them work with them as a group and be like,
Hmm.
listen, this is a safe space, right? Like I know that the
Yeah.
burdens are put on you, but if you can't talk about it here and we can't do it here, like, why were guys leaving? And that's what it was. One of them was like, listen, I'm embarrassed. I'm embarrassed that I don't feel like I know this, or I'm not strong in this. And I'm like, but you have to speak up. All right, you have to say,
Yeah.
and
So yes, we need it to be safer to be wrong and to learn.
yeah, I mean that's how you learn, right? Like I guess some people learn under pressure like that, but it's so much more rewarding. Like watching them walk out, from a case that was like bad, right? Like I had a crashing cirrhotic the other day. So you can imagine this case. If you remember what cirrhotics are like in the hospital, they're not good.
I don't know what a cirrhotic is actually.
Yeah. So a patient with liver failure.
Oh, cirrhosis. Yeah.
Cirrhosis, yeah.
Okay.
And in the hospital, they decompensate very quickly. So you have to be able to, recognize it, think on your feet. So the intern came to the floor call, right? The patient looks bad, they're diuretic, they're hypotensive.
Mhm.
They have to do some stuff, but they really need to call their
Yeah.
senior resident. Um, and just to see their faces and everyone, we did eight scenarios, and only two cases the patient lived because the team worked together. The other ones, I killed the patient on all the time. But it was what came after that, right? It was you actually did all of this really well, right? You did this, you came in, you had authority, you did this. Where you guys didn't do so well was here, right? It was this part, it was this part. So how do we make that better? That is how they learn, right? I don't know about you, but I was scared to death to make a mistake on a patient. I still am, right? I
And that
don't
makes
want,
sense because we care about our patients and no one wants to cause harm. And
yeah.
I think so, which bring circling back, right, to late diagnosis. When I accepted my late diagnosis, I also had to accept that I missed a lot of my patients' diagnosis of autism and had caused harm in that way. Um, because the way I was trained to recognize autism in residency um, was not correct and up to date for, it's the diversity of presentations,
Yeah.
especially in females
Yeah.
and those assigned female at birth.
And we hear
So
that.
yeah, that's that's hard.
Mhm. And a lot of women that are now women physicians that are now speaking out about women's health just in general, not our particular population, but just, women's health in general, which I'm glad to hear. But a lot of them will say that, right? They were like, as an OB, it's a lot from OBs. They're like, I was trained completely wrong, right? Nothing that is actually true, like not in the baby realm
Yeah.
of like delivering babies, but in the women health realm. Same thing that you're saying. I was using the wrong diagnostic criteria because that's what I was trained to do. And they're saying the same thing. And I think the importance of that is that we stand up and we say, we were wrong. we now understand and we've dedicated our career to making sure that we have the best information that we can at the moment. And we're always going to look for that more information. We're always going to be curious. We're always going to be looking at the studies, analyzing it. Does this matter? Should it impact my practice? Should it not? What's going on so that we don't ever have that happen again because it does feel
Yeah.
crappy.
And I
Um,
think it's important to pause and ask yourself, how might my patient actually be right?
yeah, yeah, absolutely. Because
Especially when we're feeling defensive.
yeah, and they know, the patients know, right? And you're absolutely right. If you, as a physician, if you feel, and there's,
And patients can be wrong too, of course, like we can, right?
yeah, yeah. But to me,
but
that's
but
actually
but
the
we
fun.
also have to be like take a non-defensive and just question like maybe what piece of this might like how might my patient actually be right?
Yeah, or what part of this may I not understand, right?
Yeah,
Am I missing a piece? It's kind of like that
yeah.
safety piece, when I always teach the residents too, when a nurse asks you something 3 times, you need to stop and rethink everything and make sure that you're not missing something. Or why are you asking the same thing 3 times, right? Are we missing something? What about this patient? But it's the same thing when you start to feel that like, okay, almost like they're attacking you because it's like, well, you're wrong or whatever the case may be. I feel the same. I take that deep breath and I'm like, okay, what's really happening here? And like maybe, they know something I don't. And patients are very educated now, right? They come in and they have a lot of misinformation, right? Because they're getting it
Yeah,
off.
that's really tough. There's like it's I mean, I don't know. I feel like misinformation might be like the downfall of the human race. And how we finally like get wiped off the planet, unfortunately, because the degree of misinformation and anti-science information is so huge.
Yeah.
I think there's a especially in my field of psychiatry.
Yeah.
Yeah.
Well,
It's
and
kind I feel like being a psychiatrist is kind of like walking into a job interview where every single interviewer has heard all these horrible, terrible, dramatic, bad stories about you. And
yeah,
that's what it's like to be like, hello,
every day.
I'm
Hi,
your
I'm Dr.
psychiatrist.
Yeah, I'm Dr. Reader.
Oh my
Okay,
God, you're gonna give me
yeah,
drugs.
yeah. And information is so readily available. And I didn't say good information, right? I
Yes,
just said
yes.
information. And I spent a lot of time doing that too, where people are like, oh, well, so and so's cousin, so and so that's on TikTok said this. And I'm like, okay, let's unpack that a little.
And there's some good stuff on TikTok and there's some
There is.
terrible stuff, and I will say a lot of neurodivergent women are big researchers.
Yeah.
So I I don't know why this is, but I feel like maybe it's part of like allistic, which means non-autistic culture that um asking the doctor too many questions is disrespectful or something. Like I love to be asked questions. I'm like, what is that? What's up with that? Right. And then I think the other weird thing is when a woman comes in and they have this list, they have a little bullet point list of like, this is why I think I'm autistic.
Yeah.
Why is the physician automatically suspicious of that? When I'm like, that's what autistic people do. Like they have a question, they research the question, they make a list of evidence to, support their hypothesis.
Yeah, but also like why in medicine is that threatening? Like if you're gonna go buy a car, you have all these questions
Right?
about the car,
I love it.
write
I'm
it
like,
down.
great. I'm gonna paste this into my note, guys. Thanks.
Right. Like why are we threatened by that? Right? Like why are we threatened by patients having knowledge? But I also think that's part of training.
Yes.
The old way of medicine is I'm the doctor, do what I say. And
Right.
I'm sure you and I have never practiced that way because I've never been that way in my whole life. But that's like the old dogma, right? Like I'm the doctor, you're the
Yeah.
patient. When really this is relationship based, right? I'm learning as much from you as you're learning
Yes.
from me. And that's really what it should be,
So,
right?
like, I'll tell people, for parents I'm like, I may be an expert on autism, but you're an expert on your experience on yourself. Or if they're a parent, like, you're the expert on your child.
Yeah.
I'm just the expert on a particular condition.
Right.
So then it's like two experts coming together
Yeah.
with different areas of expertise.
Right. And I tell women that all the time. I say, you're the expert of your body, right?
Yeah.
So I can tell you, and that's actually why I did the biology of the neurodivergent women course, because we're
Who
just
made
getting,
that course? That's interesting.
I did.
Oh, you did. Oh, sorry. When you say did, you mean you like created that
I
course. I didn't know
created
you
it.
created a course. Oh, okay.
I actually did.
Cool.
I did it on Substack, and it was basically to go through.
Oh, I'm not on
Um,
Substack. Sorry.
you love
but
Substack.
but okay, I'd love to see your course anyway. That's cool.
But the whole point of that was to take the woman's experience, right? And
Yeah.
then just put the science to it, right? Like, so it's more of like, hey, you feel like this, and here's kind of why,
Hmm.
or an explanation could be of why you feel like this. And there's a lot of validation in that, right? There's a lot of like, oh my gosh, this has been happening to me for years and I never knew. And then now, like, oh, now I know. So is there something I can do? Yes, right. And then I would see many women from all over them would be like, oh, I've tried, I've done X, Y, and Z, right? And it helped this. I've done this and this and this and that and this. And the talk though, and the community and the
Yeah.
understanding, putting names to things and understanding is what's, I think the most important. And not having one of the most beneficial things I think that my patients say to me is that I've never had anyone like listen truly the way you do. And that is like the easiest part of being a physician, right? Like think about our years and years and years of training, and they're telling me
I
that,
think it's a hard skill though to like truly listen to someone where through that listening process and your reflections back to them, they actually gain a deeper understanding of themselves and can gain access to things they wouldn't be able to access if you weren't listening in that depth. So
yeah.
I don't know. I think that can actually take a lot of practice and is a skill that we need to hone over time.
Yeah, no, I think you're right. But no, you're right. But in the realm of like all the things we study and all the things you have to do, and
Yes.
it comes down to like you just have to listen well. Of course, you have to have
Yes.
all that other knowledge, right? But like you could be the like think about surgeons, and I love them, right? But like people are like, oh, they have terrible bedside manner. But if you need a very specific surgery and it's on your brain, like who cares what they are at the bedside? You need them to do that piece on your brain. We have all of these things, but sometimes the most important skill that we can give a patient in addition to our expertise is active listening and like you said, reflection back that they
So
feel like it's a part.
there's data on this. There's a study. There's a study on an antidepressant, and the most interpersonally effective psychiatrists got a better response rate with the placebo pill than the less interpersonally effective psychiatrists got with active medication.
Wow.
So,
I just got the news.
um, yeah. So
Yeah.
think about that. Like your connection to be accurately seen and understood by another human being and accepted, and then to gain deeper understanding of yourself in the process is a therapeutic intervention in and of itself.
Yeah.
And then that brings up, you mentioned burnout, so I think that speaks to why burnout in physicians is such a loss, because when you're burnt out, you lose your ability to do that. You lose your ability to connect. Or if the appointment is only 10 minutes, right?
Yeah.
There's so much pressure in a capitalist society and in medicine to churn through people really and like lose that therapeutic intervention, unfortunately.
And you actually will because the pressure is on you. You're not in the moment. If you have 10 minutes and you have 40 patients, you're like on to the next moment, even in the moment, right? Because you're like,
Yeah.
Oh my God. Okay. I got 7 minutes.
That's the pressure that's on physicians.
Yeah, yeah. And I always tell people that the system is broken. It's not that physicians are bad or like we have probably plenty of colleagues that work in that broken system and they're amazing humans. They're amazing physicians, right? They're in this cog wheel of a broken system that isn't allowing them to be able to, be the type of doctors that they want to be. Or I would even argue some don't even know, right? Like what the other way is, right? Because we've just been groomed, like you and I talked about, for a certain way, and we just like see that way, and that's all we know.
Yeah. There are people who refer to psychiatry as medication management,
Oh
and that
yeah.
always makes me cringe, right? Because I'm like, I don't manage a medication. Like, I am a psychiatrist treating a whole human being in relationship with them. Um, so yeah, so I think I'm hoping, um, you know, like it's hard because I'm sad that because I don't take insurance, less patients have access to me. And I'm grateful that because I don't take insurance, I can spend time with people
Yeah.
and practice exactly in a way that's more aligned with my values and what's effective. Um, I wish I could have both at the same time,
We need
right?
donor. We need donors. I feel the same way. And I always say, I mean, I feel very bad. I want to help everybody possible, right? Anybody in the street, but that isn't possible. I understand that it costs money and it's not possible. But what I do think though is that the more of us that band together, I don't want to say against the system, but the more and more physicians that go into private practice, the more and more standardized it is. And eventually it's going to be accessible to everyone because it'll be the way. I had a business mentor who said that he was good friends with the guy who developed the guy who developed Whole Foods. And he said, listen, he said, back in the day, they used to be like, oh, whole paycheck, right? Like this place is so expensive and this. And he's like, and now look, like Walmart has an organic section, right? All the places have this organic section. He's like, but you have to start somewhere, right? And you have to start it if you want it eventually to be for everyone. And I do believe that, like as physicians, if we band together and, more physicians are in private practice, that we eventually, it's going to take a long time, but like the goal is going to be that we can change the face of healthcare and with our patients and empowering them too to start demanding more from a broken system. I mean, they have way more power than we do. As we can't, they can change the system 10 times faster than we can. We just have to get them to, rise up and demand it. But I hope that all of that happens because every person in the entire world deserves the type of care that we provide.
I think that, and also like my heart goes out to physicians out there who are really doing the best they can um in a crappy system.
Yeah, 100%. Because as you know, it's scary as heck to go into private practice, right? And not everybody can do that. Not everybody wants to do that. Like we're physicians, right? We're not taught, I don't know, maybe you did some business courses, but I certainly didn't. I just learned
Mm-mm.
everything as I went, right? And that's really
I
scary.
have zero interest in business
Yeah.
courses.
Me too. But it's really scary, from that perspective. And I
Yeah,
love
and there's a lot of stuff I gotta do that I really don't like doing owning a practice too.
Yeah,
Like,
like I mopped the floor this morning and I really didn't want to do that.
yeah. Okay, well, I don't mop the floor. I was thinking more of like hiring and
Yeah.
firing and front desk, this or that. But
Yeah.
um I think that um I think if people could start to recognize the value of taking time with people, not just to like get the full picture, of course, of what's going on with the patient with lots of complex illnesses, um, but also to empower that person for towards healthy lifestyle changes, to educate that person about all these various diagnoses, and to help them feel seen.
Yeah, it's powerful.
Mhm.
Powerful. All right. Well, I don't want to take up any more of your time.
Cool.
I really appreciate you and
Thank
all the
you. Appreciate you too. Thanks for having me.
yes, and thank you for being a part. And I'm going to talk to you soon.
All right. Take care.